My name is Matthew.
Hi,
Hi, I'm Marlena, and I'm the nurse supervisor.
my name is Megan R., and I'm going to be the nursing director.
And my name is Megan M., and I'm going to be the case manager.
And I'm a floor nurse in this situation. So we're all getting together to do a committee on workflow on our unit. And what I'm going to do right now is just describe to you guys the definitions of the workflow itself. And our problem on our unit is going to be discharges and admissions. So according to Carrion 2012, they define communication, coordination, searching for information, interacting with information, and problem solving and planning as part of workflow. She also notes that interruptions, switching, and walking are just a few of the human factors to be considered in workflow. These things are detrimental to our workflow on the unit.
Another potential issue is the idea of workarounds, and Flanagan et al. Published an article in 2013, and he used the definition of workarounds by Koppel et al., who states that they're actions that do not follow explicit or implicit rules, assumptions, workflow regulations, or intentions of system designers. So with this, nurses don't follow the set rules within the EHR system. The nurses could override something that the EHR is alerting to save on time, but this process can lead to errors when it comes to something as vital as medication administrations. So, as Flanagan states, this can result in an incorrect timestamp for med administration if the nurse were to give a medication before or after documenting it on the MAR, which could lead to meds being administered at incorrect times in the future.
And in Jennings' study on turnover, admissions, discharges, and transfers, they state that admissions were seen as more of an interruption to workflow. The type of admission, whether they were anticipated or unexpected, and the level of intensity demand determined the level of interruption that the nurses experienced in their workflow. In general, discharges were viewed as more predictable, quicker, and less invasive and intrusive.
And just contributing to what you said, Jennings 2013 stated that admissions were unpredictable compared to discharges, which in discharges nurses can plan proactively, which results in the admission process becoming a greater contribution to the interruption in workflow.
And according to Abram and Reddy, patient transfers involve multiple departments. The patient transfers workflow impacts not only activities within a single department, but also activities that take place between multiple departments. Hence, one of the key features for maintaining effective patient transfer workflow is developing seamless interdepartmental coordination technologies. I know in our department that is true, and that something communicating with the other departments is somewhat difficult. Now, according to the Workflow Assessment for Health IT Toolkit, we need to determine system requirements for the nurses during the admitting and discharge process. They suggest we create checklists of job tasks and system requirements, create flowcharts of key processes. Marlena, you have some more information on that, right?
I do. So I created a workflow chart that I'll share with you guys. Can you see it?
Yep.
Great. So it's based off of Frith 2015 Workflow Support Applied Clinical Informatics for the nurses, their flow chart, and I just filled it in with experiences that I've seen on the floor. So like Jennings 2013 has stated, discharge begins at admission, and longer and more complicated discharges will need to have longer planning. So then we have the admission, triage happens, they get taken back, the primary assessments are done by the nurse and followed up by the HCP, and that's where tests and diagnosing labs are ordered. Then again, taken and reviewed, that might take a while, and then the nurse reviews them, calls it HCP with an SBAR report. And from there, the patient receives treatment and given the medications. So during the hospital stay of the patient, there could be complications. Things might have been overlooked in the EHR or not documented, therefore leading to an extended stay. But after the patient has been there for a while, they come to a resolution, they're doing better, and it's time for them to be discharged. At this point, all orders need to be signed and printed. If they're getting medication, if the case manager needs to order special equipment, this is a part where that all needs to be coming together. And before they have the official discharge, verification needs to happen of where this patient's going to go. Are they going to go to a skilled nursing facility? Are they going to go home? All the documents need to be printed in their primary language so there's no confusion. And again, if they need anything at all, it needs to be there. At discharge, the patient signs the documents after being educated, and if the patient's family member comes and picks them up, this is probably the time where they will have questions, which can delay, again, the discharge process.
Definitely. And I found some supporting research about different causes for the interruptions in workflow for nurses. So the first one is from Cornell 2010, which states that electronic medical records require increased documentation time and decreased critical thinking, which impair the nurse's workflow. Log-on times, computer availability, and technical support are factors that can contribute to this increased documentation time. I've observed that computer availability seems to be a huge contributing factor to whether nurses charted on their new patient or not. When you have doctors, nurses, and students and other healthcare providers trying to chart with limited available computers, it makes it hard to sit down and do your extensive admission charting, especially when the doctors have priority over computers.
And I know as a nurse on the unit floor that is true. It's always such a hassle to walk across the unit to chart, and oftentimes I have multiple things that come up between finding time to chart.
Another cause of interruptions I found was from Yang et al. 2012, which states that one of the barriers to clinical workflow is the location of the patient's chart. More specifically, a study of nursing workflow supported these findings that hallway locations to charts produce a substantial delay in documentation. I feel that one way we could solve this delay is by putting computers in the patient's room or some way to access the patient's EMR in each of the patient's room. And then this could eliminate the problem of having to find a computer to chart at. It would also eliminate the distractions that nurses get in the hallway.
Yes, I've seen many nurses get pulled away in different directions once they come out of rooms to start charting.
Yes, awesome. And then another more supporting evidence I found for causes of interruptions is from Brixley et al. 2005, which supports Jennings' study of interruptions to workflow, which identified that the location of frequently used services outside the immediate workspace has a significant impact on interruptions. The findings of the study suggest that the physical layout of the workspace in certain departments should be analyzed further to decrease the amount of time nurses have to spend walking to and from areas to gather all the needed supplies. In the clinical setting, during the admission process, there are several different services that are not used in discharge. For example, obtaining vitals, changing bed sheets for transfer patients, like if they have blood on their bed or something, changing gowns, performing a full head-to-toe assessment, including documentation, are all things that nurses perform upon the admission process. Nurses would have better time management and decrease interruptions if there was automatically a vitals machine in each of the patient's room, along with a computer to document the head-to-toe assessment, instead of trying to find a computer at the nurse's station. And I found this information from a nursing article titled Interruptions in Workflow for RNs in a Level 1 Trauma Center.
Yeah, you bring up a really good point regarding the vital signs in the room, along with having a computer. it's especially important that timely vitals data is in the patient's chart. Ying of 2012, he states that this delay can lead to undetected patient deterioration and possible adverse outcomes. Having a computer and vitals machine at the bedside allows the nurse to document the vitals in that moment instead of writing it down and documenting it later, which can decrease the potential for errors. It would also be beneficial to have the vitals machines that are linked to the EHR system. Therefore, as soon as the vitals are obtained, they can automatically be transmitted from the machine itself into the patient's chart, which could enhance workflow by improving the efficiency and reducing the risk for errors that might occur when manually entering the information.
Right. So traditionally, like patient care technicians get vitals. There's not a lot of them in the units, but it would be nice to have vitals machines in the rooms to delay documentations. The nurses rely on them, especially when giving things like blood pressure medication, to have those vitals documented before the morning meds are passed. Putting them in the rooms would allow vitals to be done without any delay or wasting time trying to find the machines.
Exactly. And an article that was published in the Journal of Nursing Administration by Watkins et al. In 2012 aimed to evaluate the relationship between health information technology and unit layout and their impact on nursing workflow and patient-centered care. And they found that decentralized nursing stations, so they're essentially immediately inside or outside of the patient's rooms, allowing for direct observation and including medication and supply storage, a hand washing facility, work surfaces for charting, a computer. All of those things could lead to a decrease in falls, which in itself would lead to a decrease in workload for the nurse. Having these needed supplies closer to the patient's room would decrease the patient's wait time for medication, which would also reduce the potential alerts in a MAR if a medication isn't administered on time. And this article found that documentation at the main nursing station led to lots of inefficiencies and patient safety risks, as well as decreased workflow efficiencies due to nurses having to walk more and not visiting the patient's rooms as much. The patients also reported more pain when the nurses documented at the main nurses station. And they also found that the use of computers on wheels in the hallway exposed the nurses to distractions and being pulled away to other tasks. Computers on wheels and handheld computers could have docking stations, monitors, and even power outlets in the vicinity of the patient's room, or even better, like at the bedside, which would decrease the distractions for staff. I found through my experience that when nurses are charting in the hallway, they tend to get pulled away from their tasks by doctors, other nurses, techs, basically anyone, because they're right in the hall, which could cause a delay in real-time charting. When the nurse is able to chart in the patient's room, they're less likely to be pulled away and more likely to achieve the real-time documentation, which could increase the efficiency, especially when documenting admissions and discharging patients.
Valid point. However, even if they were doing paper charting, the nurse still has the opportunity to be pulled away from their charting. This is part of the characteristics of workflow as Frith 2015 has described in the Applied Nursing Informatics. I've been in situations myself where I was trying to finish documenting in the paper charts and I had to stop 3 times. So how do we decrease these interruptions during discharge, and should we add something like a time limit on how long a person has to wait, or like when from the time the discharge orders are put in to the time that they actually leave the facility? Should we have a time limit in there? Documentation, I agree, does require a good amount of time so that it's detailed enough for the HCP to get a whole picture of the patient and how they're doing, as described by Penyor, 2014, in the journal Healthcare Management. Penyor also mentions documenting took up at least 4 hours of the nurse's time during a 12-hour shift. So something as simple as wanting to speak to the HCP can delay the discharge as stated before, and by not obtaining that signature can have a domino effect with discharge where other patients are waiting for either their medication or an admission coming in or just being discharged as well. So yeah, just kind of thinking about where we should go to decrease the discharging time.
Definitely.
I noticed that some charge nurses helps the floor nurse by getting important health education information collected into a packet for the floor nurse so that they could just go over the material with the patient. The charge nurse just printed out that info and had it ready for them. Perhaps if the charge knows a patient will be discharged, they can step in by printing out that info, and while the floor nurse is reviewing the info, the charge nurse could look over other acute patients that floor nurse has.
Mm-hmm. And I also found an article that was published in the Healthcare Management Journal by Sundaramurthy in 2010, and he talked about the benefit of assigning newly admitted patients to nurses based off of the acuity the nurses has starting at the beginning of the shift instead of the amount of patients that nurse has, because the nurse might only have 4 patients, but they're higher acuity patients, so they probably should get an admission.
I completely agree with that. So one of the things that we could do is have charge nurses step in and help with the admissions process. According to a study done by Minnie et al., who measured non-direct patient care factors influencing the workload and workflow of nurses at a Belgian acute hospital setting, listed as some of the top 10 factors influencing their workload and workflow that they found was basically high patient turnover and interruptions. And these are things that nursing managers have the ability to kind of mitigate and step in and help out with. So if a nursing manager sees that a high acuity patient is admitted to their unit, they could assign that patient to nurses that have the least amount of patients, or maybe nurses that have less acute patients. We could also use an interview-like question to measure workflow after the implementation of the system to see if these steps have worked. So now that we know that we are going to focus on making technology at the bedside a priority so that nurses are uninterrupted, and we know that we are going to be involving charge nurses who have greater authority to make a difference in the admissions process, maybe stepping in to reduce distractions during floor nurses' admission. That would be a great way to get the nurse manager and case manager involved.
Great. So the suggestions, better communication clearly between the staff and the accepting nurse and the charge nurse. I know I've been in situations where the handing off nurse came up with the patient before the patient actually left and the room wasn't clean, and so they were sitting, taking that nurse away from her unit and having the patient just sitting there in the hallway. I've also had experiences where a patient has passed away and the morgue is still there, but again, the patient came out. There was just a lack of communication. So they weren't placed yet. Also decreasing nursing interruptions, as we said, putting those computers in the hallway are just out of the line of sight where they're being grabbed in different directions. And also having that time limit. Each, like Matthew has said, each patient will come in with an acuity score, given that to depending on the degree of acuity, giving that to people who can take them on. But also when it comes to discharge, nurses prefer the 90 minutes to have that 2-hour window of, okay, let me make the decision here, but coming down to a 60 minutes, okay, the orders are in, now the patient needs to leave. That can also give the nurses a better control over when the patient is actually discharged from the system, from the hospital. And that's also noted in Jennings EQL in 2013.
So for the evaluation of if these interventions are going to work, so to decrease these interruptions, I would just suggest the things that we referred to earlier, such as computers in each patient's room, a vitals machine in each patient's room, having the charge nurse step in and help with the admission process, especially with the higher acuity patients, and making sure that they assign those higher acuity patients to the correct nurses. And then also changing the location of supplies so that they're closer to the patient's room so that the nurses aren't running back and forth and spending more time. So we can interview these nurses after a month after we implement this and see if this has contributed to decrease their documentation time and decrease the disruption in workflow.
I agree. That sounds good to me.
Yeah, that sounds great.
Okay, so we'll meet back in a month to
Discuss how it's working. Sounds good.
Excellent. Thank you
Thanks
very
for
much,
the
Lisa.
meeting, guys.
Yeah. Thank you so much.
Bye.